examination, you may not be able to pick some subtle retinal changes. And so early detection is critical, and the current tools that we have miss subtle the retinal markers or retinal changes, and we need a scalable, low-cost, and non-invasive screening tools. And so we know that we use HbA1c for diagnosing diabetes and for monitoring diabetes, our diabetes patients. And it's a validated tool, and the development of this tool actually involved retina, the retina itself, the changes in the retina to predict the level, or rather the validation used the retina. So the retina subtly impacted the threshold perception for diabetes. So since the validation of HbA1c was used using the retina, so this was actually quite important. So let's do this. If we reverse the logic, can AI identify diabetes risk earlier than standard clinical markers like HbA1c just using retinal images? So basically our goal was to develop a machine learning model to predict the likelihood of diabetes and obviously the presence and severity of diabetes retinopathy. We know there are tools out there which can detect the presence of diabetes retinopathy, can detect the severity of diabetes retinopathy, but here we wanted to predict the likelihood of diabetes and also added the other two which are already in existence so that we can get data locally. A lot of the data that was used to predict, to develop the tools that are detecting the presence and severity of diabetes retinopathy actually use data from outside. So we needed also to have our own data. So what was our solution? We had a three-pronged approach. We used our clinical data, so which we picked from our patients. So in terms of the data, which we had a questionnaire which we gave to patients, and we collected clinical data in terms of the diabetes risk factors that these patients already had. Both the patients who had diabetes and both the patients, rather the patients who did not have diabetes are the ones who we administered the tool. And then we used what we call Cloud Vision AI, which I will explain, and what we call the FGADR data set. So this, the FGADR is already a trained neural network which has almost 1,800 retinal images. So we had to share data, cross-share data with them, and they had to share data so that we can be able to train our tool better. So the thing about AI is the much data it has, as many data it has, the better. It becomes more accurate. So if you remember, those who attended the KDSD last year, I explained the basics of AI. So basically, just to feed it as much data as possible so that it can identify a pattern and hence can predict what is going to happen. So AI machine learning model identifies patients with or at risk of type 2 diabetes using the clinical data, retinopathy grading without requiring any blood tests. So the model architecture was built on that. The clinical data set we had were the demographics, the clinical parameters, the history, and fundus findings. So the fundus findings, we had one of our ophthalmologists who used the Baker's classification for the retinal images that we collected at the clinic. He was identifying it for us, and he was grading it for us. And we fed this into the algorithm that we had developed. The FGADR data set is online. The link is down there. And we had, it already identifies the microaneurysm, the hemorrhages, the hard and soft exudates, all that. So why we put this in is to fine tune it even better and to give it more accuracy. Cloud Vision AI, we got this out of, they're based in the UAE, a group of ophthalmologists who actually came together and they put this online, and these are retinal images. This was a bit more fine compared to the FGADR because it had the aspect of macular edema and also the abnormal coloration recognition. So it made it even more fine-tuned so that even for the normal retinas that we were inputting, we could be able to identify any pattern that was already existent in the ones who have diabetes already, so that we can be able to pick up before the HbA1c has gone up. So that was, this is just a graphical representation and a summary of what we did. We have the trained model there. So we have the cloud vision AI data input, the clinical results, the clinical data that we picked up, the patient data, and we had the FGA-DR data set, all input there, so that it can be able to predict a pattern and give us, predict for us results. And we are following up the patients, and we are putting it back as well into the data. So this is just a screenshot of how the face value of the tool, what it looks like. This is the dashboard where we have the total number of patients, assessments, and the risk distribution. And so there you have the risk prediction tool. The first one there is we put in the patient information, the clinical data followed there. And then we have the retinal images, the left eye, the right eye, you input it, and then it gives us, we review the data, and then we submit it, and then it gives us a prediction. So the core technologies used in our system, machine learning, data processing. So all the data that we had, it was a lot of data, so we used Panda to be able to process it. And then the front end, which I just showed you, that was React. I think Jasmeet could explain this better than me. But so the implication is AI in ophthalmology is just not for diabetes retinopathy. It can support metabolic risk screening. The eye is the window where we can directly visualize blood vessels non-invasively. So through this window, the diabetes often quietly reveals itself long before the symptoms emerge. So in conclusion, early detection is key to prevention. Potential integration with mobile fundus cameras, even in resource-limited settings, so that we can scale this. And this could be a game changer in community screening, especially in the NCD programs that were discussed yesterday. And traditional screening is reactive. And AI may allow proactive, personalized prediction. So in conclusion, we just brought this forward in this program so that we can be able to show that this is with us, and this is the time to start utilizing these models. And I'm just putting it out to us, out there, all of us, that we can come up with innovative solutions because we have a lot of data sitting with us. We just need to solve a problem. We just need to ask ourselves the question, and these tools are available to us to make things easy. So please let us utilize them. So I have 1 extra minute I've given. So my colleague Shilpa will take us through so that reality of AI. Artificial intelligence, by the way, is neither intelligent nor intelligent. That's food for thought. We can discuss this. Thank you.
Good morning, everyone. That's nice and loud. Thank you very much. Dr. Rilwan has woken you up. I love it. So today we're going to talk about healing with AI. I'm not talking about internal healing from trauma. I'm talking about external healing from diabetes-related foot wounds. So I'd like to show you how we can leverage AI and the IWGDF guidelines for smarter wound management. What is the challenge of chronic wounds? We have come across many challenges, but to summarize, there are clinical factors and non-clinical factors. Clinical factors include the glycemic management as well as the infectious disease or infection management as such. That is something as physicians we do. Vascularity is managed by the vascular surgeons. Offloading is managed by the podiatrists, such as Fabian, as well as our other colleagues. And then access to wound care and advanced wound care does not mean only the nurses' involvement and their specialties like negative pressure management, compression, 3-layered compression management, because I know that people specialize with these things. But it also includes the right nutrition and nourishment in these patients. That is advanced because we don't always think about it. For now it's advanced, soon it should become basic. The idea is a multidisciplinary approach to chronic wound care, right? What are the non-clinical factors that challenge us in regards to chronic wounds? The lack of patient adherence to clinical advice, as well as the emotional toll that happens on patients, as well as their caregivers. Now, I want you to remember these 2 specific non-clinical factors very, very carefully. There you go. Keeping those two non-clinical factors in mind, how the AI-enabled wound care app has helped us. The AI in the wound care app that we use gives us an AI-guided tracking, helping us identify stagnation or improvement, and it helps us with course correction with a chatbot called HealBot. It's very cute. I'll show it to you later. But let's go through this video very briefly as to how I do the wound assessment. So this is someone who came to us about 4 months ago, not 6 months, 4 months ago, and that's how large the wound is. It gives us a gradation at the bottom in regards to the colors. Red means more of necrotic tissue and more of open wound. And as the wounds get better, there is a graphical representation. That's a heart-shaped wound now, but there's a graphical representation as to how it has significantly improved. So we center the wound, and it's going to tell me that I'm taking the wrong image. I should have flipped it over right from the beginning so that the AI can pick up the borders of the wound very nicely, and then the diameter. It also tells me where to take it from, how far it can assess from, and I've clicked the picture, right? We make a circle around where clinically, as us humans, have seen where the wound is. And then I draw a line across with a diameter. And yes, we can see pictures, and we can see improvement through pictures, but some patients or some PWDs prefer to see percentage-based improvements. For us, this wound is shrinking, but for them, it may not be. One, they may have retinopathy and other eye-related complications, and they may not be able to assess correctly. Two, they can be fussy. Giving them an objective number makes a difference. I'll show you more charts, but I have, it's not very clear, but you can see that the graph has gone from all the way up there to down there. That means to say that the volume of the wound, the surface area of the wound has significantly reduced. Why this is important is compliance. When you tell them, please give me 4 to 6 weeks, come, get dressed with us, we will show you improvement. If you're showing them objective improvement, it makes a big difference, and their compliance improves, as well as the emotional toll also reduces. What does that give us as clinicians? Better outcomes, better patient outcomes, right? And an improved quality of life for them, a reduced economical burden for them because they're coming regularly, they're being compliant with their dressings, they heal quickly, and just a small caveat, it's better for our environment as well, right? So this is someone who came to us in January end. The usual, he was feeling cold, he exposed his feet to the Jiko, he developed a blister. About 2 or 3 weeks after he developed the blister, he came to us. And this is the amount of necrosis there was, and there was a very minimum amount of healthy tissue there. And that showed us the red. That is the unhealthy tissue. Black is the necrotic tissue, and yellow is represented by the amount of skin that the image sees or the AI picks up. Over weeks, I think this was in March. This was in Jan, he came to us in mid-Feb. By March, you can see that this yellow has completely, it's been completely filled up, and the amount of necrosis has reduced. What more objectivity do we want for our patients? And they will feel so much better. So this is the graph that we show. This is the amount of surface area of the wound that's coming down. The red has come down to almost 1%. And the area has objectively, not ruler-wise, because the patient's going to say, Dr. is not doing it right. So you tell them the mobile is doing it, and they probably believe that a little bit more. So the volume has reduced from 3.9 to 1.3 centimeters squared. It will still take into account callosity and the ongoing epithelialization as a wound until it is completely healed, and then I key in, yes, now it is completely healed. It takes 6 weeks for proper epithelialization and normal skin to set in. May I please have this video? This is the guidance from HealBot, right? I have written there, what is the use of honey in diabetes-related foot wounds? Yes, I have to be appropriately spelling this out. So the HealBot's telling me that the use of honey in treatment for diabetic foot ulcers is not recommended because it goes back to the guidelines and it guides us from there. this is a point of contemplation. I'm one of the people who say thank you and welcome. And please, it's important. That one, even if it's an environmental burden. Apart from that, as a clinician, it helps me do research, it helps me document my wounds objectively as well. So every day, all the data that I key in, including what dressings I've used, how long it's taken for a wound to heal, where the wounds are, etc., makes a big difference. And I can pick it up from that app. I talked to you about compliance, and I talked to you about I need to talk to you about the importance of DSME and culture-based DSME. It makes a big difference when the DSME includes, or the structured education includes, the fact that you communicate to the patient, the nurse or the doctor communicates to the patient that the percentage of healing has significantly improved. This was a study done that showed that the use of the app combined with nursing consultation increased the adherence to foot self-care in individuals living with diabetes-related foot complications. Again, what more do we want? So why use AI? Why leverage AI? It gives me a motivated PWD who comes and is compliant with their dressings because I give them percentage healed. The data analysis happens via photography, so it's a little bit more accurate and more objective. And of course, the heal board helps me course correct whenever I need to. This improves my patient outcomes. So call to action is, patient-centric care is the key. It's not about you doing everything. You have to involve the patient so that they can be compliant with the dressings. They need to come in, they say, oh, I've healed. Daktari, how many percentage have I healed today? I'm like, okay, fine, another 2% you've improved. Let's make a difference. Oh, see, this week you've not offloaded. I told you to stay off the foot. So you've not offloaded. Next week, offload. It makes a difference, yeah? Guideline-based therapy should be at your fingertips with the help of HealBot it is. It's not difficult at all. And I would encourage all clinicians to use and adopt clinical smart wound care tools. AI in medicine is not about replacing doctors, but more about augmenting their ability to provide better care and make better decisions, right? So saying thank you for the opportunity, and please continue to say sorry and thank you and welcome and everything else.